cataracts, 81% were cataracts, 15% also had clear lenses, 2% were pseudophakic, so we excluded them because we didn't want pseudophakics to be included. So the total sample was 132, and now these are the results. So pre and post dilatation, anterior chamber depth, it's bound to increase, right? So it was found to be statistically significant. This is how the median shows. Then again, axial length, surprisingly, just about statistically significant with a significance of 0.04. And it does increase slightly. This is how it is. Then lens thickness. Yes, we know lens thickness, once the pupil is dilated, what will happen? So yes, so there will be a change and there will be a decreased value after dilatation. But do you see that the trend is more towards less, and this is statistically significant again. Surprisingly, there was a trend towards a slightly increased CCT. Very slightly, not very significant when it was actually measured, but yes, there's a trend. These are all trends and their p-values are significant. Something that's really surprising, which we could not understand, was why K1 was not significant, but K2 was significant, something in IOL master, but this needs to be studied further. Sorry. And now we are just comparing the Barrett's versus the SRKT. So I'm sorry, this is the Barrett's and this is the SRKT. Sorry, the title is not changed. But yeah, SRKT surprisingly did not show many changes between pre-dilatation and post-dilatation, whereas Barrett's did. So, and age differences were not there. Clear versus cataractous lenses, there was not much difference. Genders, yes, males showed little more difference pre and post dilatation. So summary is lens thickness, CCT, ACT, axial length, everything is significantly different. K2 may need to be significantly looked into. Males and females have slightly different.
Time is up.
Thank you. And that's it. And the final thing is that the take home is that yes, undilated may be better, but it may not translate fully into clinical change in IOL power because the clinical changes in 0.5. But however, if we want to go for toric, maybe especially for males, dilated should be avoided, and in toric, undilated would be better. So thank you. These are my references.
Okay. One question. So what do you prefer routinely, SRKT or Barrett's?
We usually use Barrett's, but we use it always in undilated. So this was a study specially done as to know, because students especially, they're tempted ki dilate ho gaya to bhi chalo dekh lete hain, but finally the power doesn't change clinically, though statistically there may be some changes.
But this is theoretical, but practical life, once you dilate, if you confirm the cataract and then only you do the IOL power, or you call the patient on the another visit?
We usually do that, we call again, but this time now, since a few days, we just evaluate the cataract based on the vision also, and then we know it's clinically or visually significant cataract and we'll need to operate it. So usually then we just do an IOL master before, because we are a government setup, so the patient doesn't have to pay for it.
Yeah, so, that makes sense, because like I work in a metro city, Delhi, so in a private setup, I cannot call patient on the next visit for IOL. Patient will go here and there are multiple setups.
True.
Yeah.
So it's better to do it just before if you're suspecting cataract, but definitely in males and definitely if you're using toric, but then this needs more studies, of course.
But what is why males only? Why there's a gender bias?
I don't know the reason, but definitely in all IOLs and in both the formulae, it turned out to be the difference between the pre and post was more than in females. The difference between the pre and post, but again the differences are in point something, and our IOLs come in 0.5. So clinically it may not make a difference, but just be aware, more aware in torics and in males. Better to use undilated.
Okay. Sir, I would like your opinion. Do you have any experience of this gender bias?
This is the first time, and this was put through this data. So even we are very surprised. Why should this turn up like this?
I don't know about the gender bias. Also the studies tell that there is no difference. Exactly. The dilated and undilated.
There's no difference.
Yes. Somehow, if we suspect cataract and the patient is somehow willing or planning on, we just do a biometry without any charges. And then we dilate the pupil.
So what?
Like we said,
Okay.
we've
So
shifted
what
to
is your
doing that.
opinion?
I don't think there's any change.
There's no change in the
Clinically, there's no
Yes,
change found
yes,
because the
yeah.
same values were there pre and post 20 to 20, but those points are picked up by the statistical formulae. So that's the reason why there's some very few conditions where statistically significant and clinically not significant.
Yes.
Kabhi ulta hota hai that sometimes we find clinical trends and we don't find it statistically significant, but this was the opposite.
So thank you for the nice
Thank you.
talk.
Thank
Now I invite Dr. Vinod Kumar Arora sir for his talk on comparing outcomes of transepithelial surface ablation to femto-LASIK for high myopia surgery.
Thank you so much. And my topic is comparing outcomes of the transepithelial surface ablation to femtosecond lasing for high myopia surgery. Earlier, surface ablation was restricted to LASIK results, but the scenario has changed now. Our purpose is to compare the 1 year outcomes of transepithelial surface ablation with femtosecond LASIK for high myopia surgery. For this, it's a retrospective study. The data was collected from 256 eyes of 135 patients. The two study groups were matched by age, gender, and baseline uncorrected distance, visual acuity, and refractive astigmatism. The machines we used, the examiner was wavelight telecrutor laser, while the femto was IFS 150 for LASIK. The surface ablation was done with a streamlight software in the wavelight machine that's called transepithelial surface ablation. There's a number of patients, out of which 256 we have got 156 for femtosecond and 98 for advanced surface ablation. The myopia range was high, that 6 to 10 diopter of spherical equivalent, that is including the cylindrical number also. In both the cases of hyperopia, compound hyperopic astigmatism, and dropouts were not included in the study. The cylindrical was restricted to -4 diopter in both the cases. The best corrected visual acuity was achieved in femtosecond in just 3 days, while in surface ablation it took 10 days. Major complications were nil in both of the cases. Minor complications were there in femtosecond around 7 and surface ablation 8 cases. Pain and irritation was much less in femtosecond LASIK. It persisted 5 to 6 hours, but for surface ablation it was high, also it persisted for 12 to 24 hours. The visual acuity after the procedure was in femtosecond LASIK, it was around 95% patient achieved equal or better than their pre-operative visual acuity, while in surface ablation it was 98% of the patient who achieved almost equal or better than their pre-op vision. So the corneal refractive surgery, including LASIK, femto-LASIK, SMILE, and advanced surface ablation are there. PRK, once nearly lost, has returned as advanced surface ablation. The game changers are mitomycin, newer wavefront optimized epithelial removal system, and such as SmartSurf and Streamlight. The study demonstrated that ASA has good outcomes for high myopia too. Its range is as good as that of LASIK or SMILE, being tissue preserving and having better biomechanical safety. Advanced surface is gaining popularity, and our results showed that 1 year results for both techniques are comparable. However, the transepithelial advanced surface ablation results were marginally better than femtosecond LASIK. Surface ablation is one of the most effective tools in surgical armamentarium of the refractive surgeon. It is still underutilized and is a very promising and exciting with superior results. These are the my references. Thank you.
Thank you so much, sir, for the nice presentation. It's all my pleasure to hear from you, sir. Okay, yeah, please. Your name? Neha Khurana. Okay. So now we have Dr. Neha Khurana. She'll be speaking on rare case of accommodative loss after barrage laser, novel rehabilitation using topical pilocarpine.
So very good afternoon to dear colleagues and the judges. So today I am here to present before you rare case of accommodative loss after barrage laser in myopic eyes and novel rehabilitation using the topical pilocarpine. So topical pilocarpine in presbyopia is a hot topic nowadays, so probably I thought this was a relevant topic. Accommodation, as we all know, is mediated by the short posterior ciliary nerves. Damage to these nerves is a rare complication after retinal photocoagulation. So we report a case of accommodative and pupillary paralysis after barrage laser, which was managed using dilute pilocarpine drops. So this 18-year-old female, she presented with flashes and floaters. She was a myope and had multiple lattices with atrophic holes in the fundus. Barrage laser with indirect ophthalmoscopy was done in both eyes uneventfully using a double frequency anti-AIG laser. Till now, everything was fine. So the next week, 1 week later after the laser, she presented with inability to read, headache, glare, near vision reduced to N18, pupils were dilated, pupillary reflexes were diminished and symmetrical. Unremarkable well lasered fundus was there. There was no fluid in the macula or anything. Distance aided best corrected visual acuity was stable at 6/6. So now we diagnosed her with bilateral internal ophthalmoplegia because he had accommodative as well as pupillary paralysis, probably secondary to the SPCN damage. So how did we confirm this? We confirmed this with a dilute pilocarpine test. We administered 0.1% pilocarpine in both the eyes, and we saw that the pupils which were totally dilated, they constricted to pinpoint pupils. So what had actually happened was denervation hypersensitivity. As in this picture we can see that this is the normal synapse with normal number of receptors. So now if there is decrease in the acetylcholine because of the SPCN damage, what happens is that there is an increase in the number of the receptors. Receptors get upregulated at the postsynaptic junction. So even dilute pilocarpine gave very strong results. So while doing the pilocarpine test itself, we had the idea because she was a student, she had her exams coming up. So we thought, why not rather than bifocals, why not rehabilitate her with 1% pilocarpine. So pilocarpine topical 1% was started, dilute concentration was used, and she was very happy with it. It restored her near vision to N6 bilaterally with the existent myopic glasses. She had reduced glare and headache partly due to partly constricted pupils, and the need for bifocals was avoided. After a month, she presented with the near vision of N6 without pilocarpine, which she had stopped on her own. Pupils were partly constricted around 4 mm. So recovery and accommodation was noted. However, pupils were still a bit partly constricted. They were not totally normal 2 to 2.5 mm. Pilocarpine was stopped for her. So coming to the discussion part, SPCN damage due to internal ophthalmoplegia after retinal laser is a rare complication. First, it was reported in 1979. There are few case reports, handful of case reports only are there. So, and also probably myopic eyes, what we saw in our case, they have a thinner choroid, so there is a higher risk of SPCN damage. So because there is no dissipation of the heat when laser is done. Thicker choroid in diabetics, older age, and hence low accommodative amplitude at the time of PRP, and coexistent maculopathy may be the reason for less reporting of this complication after PRP, which is a much more common procedure. Literature review was done. Whatever case reports and series we could see, accommodation recovery took 6 months or less in younger patients. In our patient it was 1 month. However, in patients in their third decade or closer to onset of presbyopia, they showed poorer improvement. Anisocoria also decreased in all patients. However, residual anisocoria was present in even till 18 months in unilateral cases where laser was done. Coming to the conclusion, how to treat such a case, probably you could use our method, which we use dilute pilocarpine drops, which is a novel method, and we are not concerned about safety and efficacy, which is a known fact. For hundreds of years it has been used. How to avoid such a complication? Laser power should be used to the minimum with grey white spots. Probably if too much of barrage area is there, we can split the sitting into 2 or more. And if we are using slit lamp delivery, larger spots could be used. Thank you so much.
Thank you. Thank you for the nice presentation. One thing, just try to put scientific photographs in your picture, and especially if you have a dilated pupil, you could have clicked the photo with a phone only. है ना? If you don't have a recording system, that's fine, but you can click with your phone. Okay, so try to put photos of the patients, and even if you are you have given barrage laser, you have done barrage laser, you could have put the picture of the barrage laser, है ना? So try to put more scientific pictures. Okay.
Fine, ma'am. Thank you.
Yeah, and yes, and
That would add to a documentation which was must in this case. A documentation of pupil size was must in this case.
We could have done that. I misplaced those pictures, so that's why I couldn't put. And
without
fundus
that-
picture we didn't have at that time, being in a government
Both.
setup, so that's why.
Both, you see, without that, this is the specific documentation about that. This has been changed. So we have to show the change.
Yes.
It's all theoretical what we are talking.
Yeah. You could have done like pre or pupil size, and with a picture of a pilocarpine and after picture. That would have given the impact of your presentation more. Okay, you can improvise this presentation now also. Okay.
Then
Thank
the
you.
Photo of the PR, post PRP
Yeah,
also.
yeah. Now I call upon Mrinal for her talk on a high myop's journey, a tale of 17-year-old of bilateral phakic IOL.
Good afternoon, everyone. So this is my case, a high myopia.
Can I have slides, please?
A tale of 17 years of bilateral phakic IOL implantation. So high myopia, it is defined as refractive error greater than -6.
That mic is working. Just go
Keep it
adjust
closer.
your mic.
And often associated with axial length more than 26 mm. The management option include glasses, contact lenses and refractive surgeries. So my case is retrospective descriptive case report, presents long-term follow-up of a high myopic patient who underwent bilateral phakic IOL implantation 17 years ago, and it underscores the importance of long-term monitoring in such patients. So this is timeline of my case study, which is starting from 2007 and ended up latest evaluation in 2025. So a 21-year-old female came for regular ophthalmological checkup to get rid of glasses 17 years ago in 2007. This was the baseline examination which was done. So these are the investigations which we have done. Corneal topography of both the eyes. You can see right eye and left eye. Then IOL biometry of right eye and left eye. This is specular biomicroscopy of both the eyes. Then this was the case prescription in 2007. So this is the fundus diagram at that time. Right eye showing normal optic disc with superior and inferior lattice treated with argan barrage laser, and left eye is normal optic disc with myopic chorioretinal degeneration. So surgery was performed successfully with bilateral anterior chamber phakic IOL implantation with varicose IOL, and surgery was uneventful. Post-operative she has achieved vision of 6/9 in both the eyes. Then yearly follow-up was maintained and no complication was observed. So in 2009, patient presented with complaints of floaters in right eye and vision was dropped to 4/60, and fundus examination revealed the horse-shaped tear with retinal detachment. You can see in right eye the fundus diagram showing horseshoe-shaped tear with retinal detachment, macula's warp, and this is post-operative picture which was treated with scleral buccal surgery with cryotherapy marks, and left eye was already normal. Then again in 2010, patient came for routine checkup and we found the IOP was raised to 26 in right eye. Left eye was performing quite normal, and this was the perimetry performed in both the eyes, right eye and left eye. Then treatment was given in right eye. We prescribed the anti-glaucoma medications, and after 1 week the IOP was controlled to 18 mmHg and after 1 month patient was maintaining quite well on anti-glaucoma medications. Then patient maintained regular yearly follow-up. Then again she came in 2016 and presented with complaint of diminution of vision, and this was the examination we have performed. In right eye there was a dense PSC and vision was dropped to 1/60. So advice was given with right eye phakic explantation and phacoemulsification surgery with precautions with Viscoat and BSS plus. Before surgery, preoperative investigations was performed, IOL biometry, specular biomicroscopy and OCT macula. And after surgery was uneventful, and routine prescription with antibiotic and steroid combination eye drops was prescribed. And patient has achieved the post-operative vision of 6/9 in that eye. And then again in the year 2021, she has came for the routine examination, which was she is quite maintaining, and management was given in right eye. Posterior capsular opacification was found, so we did the NDI laser capsulotomy, and then after follow-up with 1 week. So this was the perimetry in 2021 in right eye and left eye. Right eye has shown the advanced visual field defects. Left eye was quite performing normal. At that time she is not taking any anti-glaucoma medication, so glaucoma surgeon opinion was taken, neuro-ophthalmologist opinion was taken, and she has advised with IOP monitoring and HVF24-2 perimetry. So this is her recent latest investigation in 2025, and also the perimetry was performed. And this is her recent slit lamp examination photo. Right eye she is pseudophakic with peripheral iridectomy, and left eye she is performing quite well with iris claw anterior chamber phakic IOL with peripheral iridectomy.
Your time is up.
Yes.
What is your present designation?
Sir, ma'am, my presentation is the history case report.
Designation.
Kolkata, ma'am. Trinetra.
What do you do? Like, are you a fellow?
Yes, ma'am, I am fellow.
Okay,
there.
just
So,
few suggestions. Try to present your own work.
Okay.
Whatever you do, even you do a pterygium excision, try to present that. That would be appreciated more.
okay.
है ना? Because, and another thing, whenever you are saying that this procedure is done, I know everybody sitting here knows that this is a OCT macula. We are interested in the findings, not the investigation.
Okay. Thank you.
Okay, chalo. Thank you. So I think we don't have another speaker, Dr. Kirti Reddy. So we are half an hour early. Keynote speaker? Okay, you're here. So now I invite Dr. Ramchandra for his keynote address on impact of online classes on refractive errors among school-going children, a cross-sectional study. Need of the hour, sir.
Good afternoon, everyone. I am presenting the keynote of the impact of online classes on refractive error among school-going children, a cross-sectional study. Uncorrected refractive error have been major cause of visual impairment in the world. The number of people suffering from the refractive error have been increased over the year. The most concerning population with refractive error is pediatric age group. Children already have more likely to develop myopia since there is an increased trend of the spending time indoor using computer, playing video games. The COVID era has only added this burden by the compiling school-going children to the continue their education via online classes. There has been a spike in the number of children presenting the OPD with complaint of headache, eye strain with visual disturbance and the rubbing of the eye. A cross-sectional study was conducted amongst school-going children to the OPD with complaint of the visual disturbance related symptoms between January to March 2023. History was taken about the use of digital device for attending online classes, and children who are attending online classes were selected from the study. A total 116 children were selected from the study. These children were first asked to do questionnaire, and these children were underwent complete visual assessment via tretinooscopy The data collected was compared with the data similar to the cohort database from the January to March 2019 and the results were analyzed. From the January to March 2023, total 178 children presented to OPD with complaint of visual disturbance, stenotic symptoms, and out of 178, 116 children were willing for the part of the our study, agreed to fill the questionnaire. From January to March 2019, total 122 children presented to OPD with complaint of visual disturbance and 116 selected randomly from the our study. There is a children are OPD with disturbance slightly 35% increase in refractive errors compared 2019 and 2023. And in out of 160, 67 was girls and 33 was boys which presented to the OPD. The similar cohort is 116 children with 46 was girls and 63% was boys in January, March 2029. This is age-wise distribution. In no such distribution, slightly 12 to 13 year age increase in 2023, 32%, and there is symptoms presented in OPD. Stenotic symptom, newly diagnosed refractive error has slightly increased, and the major symptoms worsening of the pre-existing refractive error in 41%. And this is a bar chart diagram. Can you show only worsening of the pre-existing refractive error increase in 47% cases, and in 38% children where newly diagnosed refractive error have only myopia and 78% cases. And the newly diagnosed refractive error, you can see myopia increase incidence. And the 47% have already pre-existing refractive error have myopia in the 81% cases has found. You can see in the bar diagram, myopia increased 2019 to 2023 year. And since the COVID-19 period has been 2020, school has been increased subject to the online classes. For the screen population, their daily online classes are range from 4 to 8 hours. Their screening time increased, therefore outdoor activity have decreased drastically. Lesson outdoor activity has known to be significant associated with higher incidence of myopia in school age children. Concerning the raised about the addiction to mobile tablet use of such a young mind, such worsened burden of myopia from the 20 to 2023 has almost 35% rise in the number of children presenting to the OPD with complaint of refractive error and the associated symptoms. Our study 33% children were newly diagnosed with refractive error, while 41% children worsening their pre-existing refractive error and the 27% had stenotic symptoms. There was 47% in the number of children who were newly diagnosed refractive, and 38.3% is number of children with worsening of their existing of refractive error. And now during the COVID-19 pandemic, digitalization of education of school-going children was necessary to continue the study, but the impact of digital devices ocular health of the children a major challenge. Use the digital device frequently and for long hours and stretching the attend the online classes have impacted severe the ocular health in many children. Children have been suffering from the ocular discomfort, headache, disturbance. This dependent on online classes has increased the burden of the refractive error in children, especially in school going among children. Myopia rise follow the stenotic symptom and dry eye. Take home message: better approach to shorter the duration of online classes and frequent break, and more importantly education the parent of such children about the patient harm exposing the increase the duration of a digital screen and the method of scrub them, and along with encouragement of the participant in outdoor activity. Thank you.
So what should we do? What should we do? We should allow children for online classes or not?
I should advise the increased outdoor activity and frequent break between the online classes.
Even when like I have two kids, one is in class 1,
Yes.
so she has daily her homework is coming on WhatsApp only. There's a one app, classroom app, but her homework is coming daily on phone. Okay, what I suggest my patients and what I do with my child is I give her printouts. I invested in a printer, so I give her I suggest all my patients to invest in a printer, take printout and then give it to children
जी मैम
for the
I
homework.
didn't
For homework, you can add that point in your slide
yeah.
for the printer.
no I reduce the screen time.
Yes.
Yes, and better to advise the offline classes, and duration of time in screen is reduced to better approach to reduce the myopic patient and refractive error.
Your opinion, sir? Sir, homework is submitted in the form of papers only. In the form of papers only. In the notebooks only they submit, but homework is sent on the phone. Daily homework is sent on the phone. So what I give printouts to them. I don't give phone. Because usually my child is in first class, so she is like little bit under control. But for the elder ones, they are like कि हम homework कर रहे हैं, but they will surf it. They will use phone extra.
So convenience teaching, I should say. I think we should take it at the AIS level,
Yes.
and then at the school screening, we should educate the teachers to avoid online work.
So I am doing
We
it.
have to motivate them, aware them, make them aware. Subsequently, they would change.
I usually conduct one session, eye care session per month at different schools. Yeah. Yes, sir.
The parents would say, tell him not to use the phone.
Yes.
So who's giving them?
We are only giving them.
Thank you.
Thank you, thank you. So, is Dr. Kirti ready here? No. So, we are before 15 minutes. So, do you want to discuss anything? Like any questions? So, should we wind up the session? Yeah, so we'll wind up the session. Yeah, all the speakers can come for the photograph.